Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for future distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the BWell Texas providers, please make sure you identify yourselves during the session. Or if you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you join by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to share your comments and questions. Please note that no predicted health information is allowed in either the chat or the discussions. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble finding this, please message Echo IT. Towards the end of the session, the Shout Texas team will send out a link to an evaluation survey. All participants filling out the survey will automatically be entered into a raffle for a $30 Walmart gift card. Our didactic today is on managing OUD in patients with acute perioperative pain and will be presented by Dr. Blair Walker. Following that, we will discuss a case presented by Dr. Yun Shi. We will start with introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining in today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Dr. Moriartis.
Hey everyone, Chris Moriarty, hospital medicine, assistant dean for healthcare value at Dell Medical School and part of the Shout Texas team.
Thank you so much for joining us. Dr. Walker.
Hi, everybody. Blair Walker. I'm with the Shout Texas team at Dell Med. I'm with psychiatry.
Thank you so much for joining us. Alana.
Good afternoon, everyone. My name is Alana Bolton. I'm a program manager at Dell Medical School and the director of Shout Texas. Thanks so much for being here.
Thank you. And Dr. Yun Shi.
Sorry. Hi, Yun Shi, family medicine here, UT San Antonio.
Thank you so much for joining us. And with that, we will move on to our didactics for today. Carly, if you could please share the slides, and Dr. Walker, whenever you're ready.
Thanks, everybody. Thanks for having me. You can go to the next slide. I don't have any disclosures, but I do want to thank John Weems, who is one of our Shout Texas team members with addiction medicine. He and I gave a version of this talk. This one's much shorter, last October to some Dell Medical School folks. So you can go to next slide. There they are. Yeah, you can pop through all of them just so we can see it all at the same time. So these are our learning objectives. We'll talk very briefly about myths associated with treating acute pain and opioid use disorder patients, just general principles, and then some management strategies. I have to keep it tight to like 10, 15 minutes max. So next slide. So first things first, we'll review some myths. So first one is that opioids are ineffective for pain. Actually, they work really well, and it's okay to use them for patients who have opioid use disorder. Buprenorphine and methadone will treat pain. So they are good options, and we'll talk about it, but sometimes if people are already on them or they're already on max doses and have tolerance to them, sometimes you need additional pain management strategies in your arsenal. Always think about potentially needing higher doses of opioids, and it's okay to do that for patients who have tolerance. Another myth is that the idea of buprenorphine and methadone blocking all opioids, and that just isn't true. And we'll talk a little bit about that later. You can go to the next slide. It being illegal to prescribe opioids for pain to patients with opioids for pain to patients with opioid use disorder. So there are kind of tricky pieces here. I think mostly the takeaway is there's a lot of stigma about managing patients with opioid use disorder. There are risks for not treating pain that are equally as high as the risk for the idea of sending someone with a short supply of an appropriate opioid. We're mostly focusing on hospital use with this lecture, and it's totally fine to give people opioids for acute pain in the hospital. The last myth is just the idea that giving a patient with opioid use disorder opioids will mean that automatically they're really, really high risk for relapse. But again, we undertreat pain for patients with substance use disorders, and not treating pain is actually probably a higher risk for people to relapse and use opioids than if you treat it appropriately. So another myth to just bear in mind. Go to next slide. So general principles, the idea is that you want to be non-judgmental and let patients have autonomy and dignity in every single interaction. Really being patient-centered and transparent is the most important thing that any of us can do in taking care of these patients and offering them care. There's really no wrong door for addiction treatment, and letting the patient be your guide is always kind of the way to go. And then, always be thinking like doctors, thinking like practitioners, instead of kind of falling into the trap of getting lost in challenging behavior. Try to understand where it's coming from, and try to fix the problem, so to speak, and be flexible within reason. So you can go to next slide. So just a nice slide that sort of highlights that this, is specific from a Mayo proceeding in 2020, but it applies to all opioid use disorder patients, not just for buprenorphine. And the idea is every single situation that you're trying to help a patient manage is very unique. And so it sort of highlights this overlap between what the acute pain is, where it's coming from, what the situation is environmentally, and all the ins and outs of what that patient in particular is going through, their preferences, things like that. So it's just a nice slide to kind of bear in mind. You can go to next slide. So general principles, I think first and foremost, we talk about it all the time, is manage withdrawal. It's the first thing that I ask about when I go into a room. You want to avert AMA discharges. It will also improve pain management, and you certainly can't help people's pain if they're gone from the hospital. So that's the most important thing that any of us can do. Obviously you want to ask about their most recent medications, if they're already on treatment for opioid use disorder and what they're on, and ideally coordinate with their outpatient treatment team. Remember, and the general very important principle is that buprenorphine and methadone can be good options for pain control, and we'll talk about that in a sec. Giving opioids that will not worsen a patient's substance use disorder necessarily, and not to be afraid to treat pain appropriately. And then always anticipate tolerance and the need for likely higher opioid dosing. These patients have higher tolerance for opioids, and it's okay to use what's effective for them. You can go to the next slide. So general approach, we talked about withdrawal, deal with it rapidly, definitely offer adjunct medications, not just opioids, not just Suboxone or methadone, but think about things like clonidine. We'll talk about kind of adjuncts in a bit. Asking about kind of current use, prior use, what their preferences are, offer guidance. Again, we're always looking at this in a patient-centered way. And I like to offer different options. And as you get comfortable with using these different medications, to kind of know where, your boundaries and limits are with dosing and things like that. And then, what you're willing to add or not. Always use multimodal adjuncts, or at least offer them. Encourage patients to actually take the NSAIDs if they're, indicated and appropriate, and Tylenol. Think about gabapentin. Think about things like clonidine, more to kind of calm withdrawal. I've also started to use a lot more tizanidine, which is used for muscle relaxation, but same class as clonidine and can help with, anxiety and some quelling of withdrawal symptoms too. With opioid adjuncts to treatment for opioid use disorder, again, like sort of anticipating higher dosing need. So next slide. So these are 3 kind of opioid use disorder treatment medications. We're going to focus mostly on methadone and buprenorphine. We're breezing through pretty quickly, I realize, but these slides are something that you can come back to, and there's a little bit of protocol in the slides that you can look at in the future. And we'll breeze over naltrexone as well. You can go to next slide. So general kind of management with methadone and buprenorphine is that, you always want to continue their home dose, or at least some version of their home dose. And we'll get to specifics about buprenorphine potentially going forward. So you're checking PMP for buprenorphine dose. And you may be able to see it in your external pharmacy link, depending on your EMR, and calling the narcotic treatment program to confirm the methadone dose and that they were on it. Patients will often say like, oh, I take 120 milligrams of methadone, but then you find out that it's been a month and a half since they've been seen. You can always call the prescribers for guidance. And I think that's one thing that, if you don't have an addiction team or somebody who has, more experience that's available in your hospital, the prescribers are the experienced ones. So call them. They will be able to give you guidance, and they know the patients, theoretically, well, or potentially better than you do if you're just meeting them in the hospital. Always consider split dosing of both methadone and buprenorphine. I think with the caveat, when we look at methadone, there are some barriers to aftercare. So your dispo can sometimes be more complex if a patient ends up really needing to be on split methadone dosing for, acute pain. The NTPs, at least in our area, read the regulations that they may not ever manage chronic pain or manage pain. And so our methadone programs in town are often not willing to follow a patient at a skilled nursing facility, for instance, and provide the methadone if they're on more than once a day dosing, which has been something that's come up more recently in our experience. I would encourage you to always work with your area methadone programs, because if you don't have methadone programs that are following in skilled nursing facilities, you might be able to get them to. We do have that in Austin, and it's really made a big difference for a lot of our patients. And then this last one is just, again, always consider additional full agonist opioids, and that they may require a higher dose than normal. Go to the next slide. So methadone, kind of the big ones, and you can click on the whole slide just so everyone can see the whole thing. These are just sort of like the pearls of methadone use. So we talked about kind of the idea of split dosing. You can also consider dose increases while they're in the hospital. And when I do that, I do it usually in addition to split dosing. Always bear in mind that there is a higher risk of QT prolongation with methadone than other opioids. If you're going to be increasing the dose or you're starting someone on it for the first time, it's a good idea to just check a baseline EKG to know what you're dealing with. Always bear in mind drug-drug interactions, given kind of QT prolongation risk, and, bearing in mind the risk for mixing other agents at the same time, especially in the hospital. I'd say being aware that methadone is a very long-acting opioid. So are some of the benzodiazepines, and long-acting agents stacking up can sometimes equal having a lot more trouble with somnolence and the theoretical risk for respiratory depression. Methadone is for opioid use disorder cannot be prescribed on discharge. They have to go pick it up and get it directly observed at a narcotics treatment program. So that can sometimes be a barrier. It's something that when I'm offering methadone is part of the discussion at the beginning, that we can do this. And if this is what you want, that's okay. But I can't get you in very easily somewhere, and I can't give you a prescription when you leave. And then the figure on the left is just highlighting something that you need to know about methadone. It's long acting, but it also takes days to hit steady state at any given dose. And so you need to be cautious with dose increases and monitoring for a number of days before you increase the dose again. And I'll talk through a protocol here in a second, but I would say the one thing I'd say is that being in a medical hospital, I think you can go a little bit faster, and I do routinely go faster than I think the outpatient narcotics treatment programs do at the lower doses to get people up to a dose that's more adequate for both ameliorating withdrawal and pain. I think it's partly because of the setting with 24/7 nursing monitoring, and we're, have doctors readily available if there's any issue, and Narcan readily available. I've never had a trouble with getting to a point where someone had like unsafe methadone side effect in a number of years of using it. You can go to the next slide. So this is a known protocol out there. There are different protocols. And so I've mostly kept it in so that you could just see a nice kind of black and white idea of a way for doing this. The general regulation in the community is you can't go past 40 milligrams in the first day. For opioid tolerant patients, if you can give them something close to that, it usually helps with withdrawal very quickly. They feel much better, even within hours. I'd say that this protocol is maybe even on the more cautious side. I will often, if a patient's ready for it, they've taken methadone before, they want to be on methadone now, get me on it, doc, give me some, I'm in withdrawal. I'll give them a 30 milligram dose right there, or we'll do 20 and 20 on that first day and then reevaluate the next day and see kind of how they want to go. I tend to go pretty quickly to get up to 60 milligrams if they're having breakthrough within even like the next day or the day after. If they're going to be in the hospital for a long time. What I have seen in my experience is once you start to get up to 80 and 90 milligrams, then I definitely slow down with the dose increase and go 5 or 10 every several days to reevaluate how they're doing with oversedation, and especially if they're on any other potentially sedating medications at the same time. But methadone is doable. You can start it in the hospital. It can be very helpful for pain as well. And it does treat acute pain depending on what the pain is going to look like and what they're going to need afterwards. Sometimes we'll get people on methadone that's split with the plan to consolidate right before they leave. So it just depends on what your time frame is, depending on a patient's particular medical situation. You can go to the next slide. So switching to buprenorphine, it's also an opioid. The idea is that it's a high affinity, low potency, and slow dissociating opioid from the opioid receptor. There is a precipitated withdrawal risk if tolerant or if early in the course of your admission and they're using chronic daily fentanyl due to the lipophilicity of fentanyl, which I know we've talked about in other lectures. I always split dosing for buprenorphine in the medical hospital unless the person has zero pain and or like particularly want to be on it once a day. But pretty much every single patient that I treat in medical hospitals is on some form of split dosing of buprenorphine. Generally, you just kind of bear in mind that the max is usually around 24 milligrams. You can go up to 32. I have rarely ever gone past that. The evidence shows that 12 to 16 milligrams is kind of a community average before fentanyl, but as we're seeing much more fentanyl across the country, that sometimes the average daily dosing for most people to keep cravings at bay and meet their tolerance need ends up being higher. So we'll split it. And I often will try, I'm very flexible with patients and kind of do what they want to do. But, we have a 4 scheduled 3 times a day plus 3 times a day as needed that they can use for breakthrough. And then you see what they end up needing and if they need other opioids on top. Bear in mind, happily, there is no extra training required. The X waiver is gone. There are some regulations that have now been kind of more solidified that have come out. And really anybody with a DEA Schedule 3 can prescribe it. That's basically like a benzo. If you can prescribe benzos, you can prescribe buprenorphine. So it is much more available, and we're all hoping that the community will kind of catch up over time and get more comfortable with this, because I think patients are going to need help from their primary care doctors and other practitioners in the community that aren't used to prescribing these things. It's very easy to use and it's very well tolerated. Mild to moderate pain. I have patients on pretty severe pain. And so the caveat is people who come in who are already on it, say they're already on 24 milligrams of buprenorphine. Now, what do you do? Because they've broken their femur or they're about to have a really big surgery tomorrow and they're coming in, kind of plan for this. And I'll show you another slide in a moment that has a figure from a really good article that came out from the Journal of Anesthesia in 2019, I think. There's evidence that there's this sort of analgesic sweet spot, but also that theoretically, if you have less buprenorphine to compete with the receptors, you can free up mu opioid receptors for the other opioids to take effect and work. And so the evidence more recently shows that even doses, you don't have to drop it to like 2 milligrams of buprenorphine a day. Even doses of say 12 a day will allow other opioids to work better. In general, I just follow patients' leads and we try something. And if they need something else, we try that. I'll put them on split buprenorphine. And if they need opioids on top of that, once they're on the buprenorphine, you can immediately start using opioids if you need to. If just monotherapy with the only opioid that's available is buprenorphine. If it's not adequate, it just isn't. And it's okay to add something else on top. What I use most commonly is hydromorphone oral over here, but our pain protocol in our hospital system, utilizes oxycodone. So that's it. I really sort of, they're usually on something when I meet them, or they have a preference, and I let them choose because it's okay. We're just, flexibility is the most important thing to kind of help them stay in the hospital. All right, so you can go to the next slide. Weems is great about talking to this. He has a really good humor. Basically, long-acting naltrexone is going to make your life hell. So if somebody is getting the long-acting naltrexone shot, you can just expect that there's going to be kind of some level of erratic kind of exposure to it. It's going to make it harder to manage pain. Just use opioids, use more. I think let your patient be your guide. If they're in pain, believe them and just do the best you can. But I think you can also set expectations with the patient from the beginning that it may be kind of hard and we're going to do our best, and always try to use, other agents. Naltrexone, we talk about it. I know that most of you know this, but it's basically an opioid antagonist. It's going to block the mu receptor and it stays in your system for a month, and it doesn't start to come out to a meaningful degree until, week 3+. So it can make things very hard to manage. I think the other takeaway to always remember with folks who are on naltrexone is that they do not have opioid tolerance if they're not using any other opioids. And so they're at high risk for opioid overdose and death, and to always be talking to them about safer practices and harm reduction and not using alone and things like that when they're leaving the hospital. All right, you can go to the next slide. So just non-opioid strategies, we talked a little bit about it, but multimodal pain control, and here's some options for non-opioid pain control. Can't underscore enough. Things like Tylenol and NSAIDs, patients will scoff at it, try to encourage them to take it anyway. It takes the edge off. It doesn't fix everything, but it can help. There is, emerging literature around misuse of gabapentin and risk for kind of overdose with multiple drugs. I think, again, we're in the hospital system. I think use what works to help them get their pain under appropriate control, and then, evaluate what you think is reasonable when they're discharging from the hospital. Don't forget your anesthesiologist to help you with local and regional anesthesia. And ketamine is sometimes an issue. We have a burn unit where I work, so every once in a while we have patients who are on a very low dose ketamine drip to help manage pain, and it can work very well. And then, plus minus anxiety control. I think benzodiazepines have a role. I use them as a later line option. I don't jump to it as an offering. But when people are in a lot of distress, if they need help, it's okay to use. And again, we're in the hospital, so you can watch them closely. I tend to use shorter acting benzodiazepines, Ativan, especially lorazepam, just because of its fairly rapid in and out and kind of liver profile. And if you have any problems, it'll come out pretty quickly. You can go to the next slide. I'm just wrapping up. This is the slide from that Journal of Anesthesia in 2019, but it just sort of highlights options and things that the anesthesiologists can help with, even in the operating suite, to minimize exposure to opioids. I don't tend to get too closely into this with all of my patients, but there are patients who are going to be very firm about, I really don't want to be exposed to other opioids. What can you do to help minimize that? And the answer is always talk to your anesthesiologist. They have lots of tricks up their sleeves. They're really good at this. So not forgetting to include them in the discussion when you need them. So next slide. I think this is sort of just recap. Don't forget to be patient-centered, communicative, flexibility within reason will serve you. Buprenorphine and methadone can treat pain, and call the outpatient prescribers to let them help you. And obviously to kind of hand off when patients are leaving the hospital, and always address withdrawal rapidly, use multimodal agents, and then don't forget the Narcan on discharge, which we want to remind everybody about. I think that's it. Any questions quickly? I know I've gone too long. We can maybe segue straight into the case, because it kind of makes sense with what we just talked about. And then we can ask the questions at the end.
Thank you so much, Dr. Walker. That was a wonderful presentation, and it's great with the case after. What we'll do, we do have a bit of time for some questions and announcements, so we'll do that. I see a question here from Polly. What do you recommend for patients who present who use fentanyl chronically for post-surgical acute pain?
Good question. We didn't talk about it in detail. I probably should have. So with fentanyl in the mix, it's very lipophilic. It stays in the system. You see a slow and kind of erratic withdrawal over at least 2 or 3 days after their last use. Every patient's different, obviously, but very commonly we'll do, and what is used across the country is called opioid bridging. So just use high and regular dosing of short-acting opioids, enough to manage withdrawal and pain for that amount of days, and then kind of offer the switch over to buprenorphine. If they're really wanting to do methadone, you can just start to use methadone if that's the plan. But those are the general kind of options. You've got opioid bridging, methadone's there. If you're looking at buprenorphine, then you either can think about microdosing with other opioids kind of present and very available, or you just go high with buprenorphine. I've had a patient very recently who's left AMA like 4 times from the ER and can't seem to get him to stay. The waiting for the fentanyl withdrawal to be over is just not the way to go. People can't wait that long. They need help, but giving buprenorphine in the midst of it can risk precipitated withdrawal. We talked a lot about it, and he took a 16 of buprenorphine, had no problem whatsoever, and his last fentanyl was the day before, and he'd actually had no opioid overnight, and a milligram of IV Dilaudid about an hour before I saw him, and that was it. But he was game for it, and he didn't have any problem at all, and he was using high dose regular fentanyl. And then he went out on an 8 3 a day scheduled. So it's really dependent on the patient, and that they have informed consent and know what they're up against, and that you have a plan with them about what might happen with the precipitated withdrawal risk. That's basically, those are your options for when you're dealing with it. And generally, you just want to be, people with acute pain, you just want to be generous with pain control, generous with opioids, believe them. There's going to be a lot of tension between potentially the staff that you're working with who are administering the medications and the patient. I will have orders there where it's very available, and the nurses need coaching that it's okay to give it to patients. And so you also want to make sure your orders have indications that aren't just withdrawal, that aren't just pain. I actually have a PRN withdrawal or pain or at patient request, like just give it. It's okay to give it. I think that's the most important thing. There's another question. Recently had a patient that took a total of 36 milligrams of to be induced and not in precipitated withdrawal, started with 12 and gave 8 at a time until she was comfortable. Yeah, everybody's different. And I think sometimes, especially at the beginning, I tend to not worry about max dosing, especially in the first 24 hours. I mean, I haven't gone much past something like 36, maybe a little bit more, but in the first 24 hours, especially, sometimes people need a lot more. And then you can back off and sort of see how they do at more kind of steady state dosing. And often patients don't need as much. I don't know if anybody else has any kind of thoughts about that or something to add in. Any other questions in there? Maintenance is 16 BID. Yeah. And we're definitely seeing, and again, I'm hospital based. Dr. Weems is in kind of the outpatient realm. They are definitely seeing higher dose as kind of steady state, especially now in the fentanyl area. So, you know, there's no rule about max dosing. It's really a guideline, and you're working with that patient to make sure that they're not having side effects. And with buprenorphine, methadone as well, all opioids are serotonergic. The main side effect that I've seen on higher dose is a touch of serotonin syndrome. So getting a little twitchy, getting a little foggy brained. The outpatient clinic will report back to us like those patients were twitching on the dose you were giving them. And so I think always being mindful, especially when they're on higher dose buprenorphine, what their liver profile looks like. If they can kind of tolerate being on that higher dose, that may increase the risk for having more side effects on the higher dose, and also just any other medications that they're on, and always running a drug checker, just so you know what you're up against, so you can warn a patient what to watch out for. And then they get to pick, do we want to decrease the buprenorphine, or do you really need to be on 30 milligrams of duloxetine? Is it doing that much for you? Maybe they don't need to be on that, or whatever it is that might be interacting that may be tipping the balance into having some side effect. Would you ever give 24 to start? I haven't ever yet. You know, gosh, that guy, I will tell you, that patient, the plan was, I'm going to give you 2 strips of 8 right now. We use Suboxone, you know, buprenorphine films in our hospital system primarily, but you know, he got 2 strips of 8, one on another side, and I was ready to give him another 8 within the hour, 30 minutes if he needed it, if he had any issue. Again, if you precipitate withdrawal with buprenorphine, you want to be giving more buprenorphine, lots more. And I always talk to patients before we start, so they know that's the plan, so they don't refuse it and are miserable. But I think probably I'd give a little pause, one, because can it all fit under your tongue at the same time and get like best absorption? But I'd be ready to give it fast if they needed it. So I wouldn't be too worried. I just, you know, I think I'd spread it out over an hour or 2 if possible.
Thank you so much, Dr. Walker. That was a wonderful discussion. We'll now move on to some BWell program announcements. Carly, if you could please share the slides. Thank you so much. The Center for Substance Use Training and Telementoring provides high-quality education to healthcare providers. CSTAT makes evidence-based practice available to addiction specialists in Texas and the US with sessions like the one you're attending today. For more information, please visit bwelltexas.org. Next slide. The Shout Echo session has been renewed. Don't forget to add the series back to your calendar. You can do this by going to the Zoom reminder email that was sent to you from noreply@zoom.us and click on Add to Calendar. That is in the body of the email. Make sure to check your other or junk folder if you don't see it in your inbox. Next slide. The new consolidated Appropriations Act has removed the X-waiver requirement. The MATE Act will require prescribers 8 hours of OUD and SUD training upon renewing or receiving their DEA license. CSTAT is developing some guidance to help meet the training requirements. To get updates and to learn more, please visit our website at cstat.utisca.edu/getwaivered. Next slide. To claim your CME credits for today's session, you must text by midnight tonight. Text attend 100-929-06 to 844-502-1338. Next slide. And finally, do join us for our next session, which will be on Thursday, June 15th. Thank you. And with that, we will move on to our case for today. Carly, if you could please bring up the case, and Dr. Shi, you can take it away.
Thank you. All right. Thank you, Dr. Walker, for that wonderful presentation. I think my case is relevant, I believe. And as I introduced myself earlier, I'm a family medicine physician. I also work in the hospital setting. So this is a case that I encountered back a few months ago while I was at the hospital. So we also collaborate with podiatry service. We help manage their medical comorbidities of these patients requiring surgery, IV antibiotics for their foot infections, as well as their more complex pain management. So this is a patient who's a 47-year-old female who had presented for this fifth toe, and she had found to have a blister on that toe, and it's turning color to be black, and then she presented to the ED and then subsequently admitted for this left toe polymicrobial cellulitis and osteomyelitis requiring surgery, IV antibiotics. And chronically have many comorbidities, including type 2 diabetes, hypertension, hyperlipidemia, coronary artery disease, hep C, had a history right below the knee amputation in the past. Also had MDD, GAD. She's on methadone for her chronic opioid use disorder. She was on 90 milligram daily. This is due to the history of heroin use. She also has tobacco use disorder in the past. So listed here are her home medications. I think more relevant is just the methadone, 90 milligram once daily. She's getting at her outpatient methadone clinic. She's also on quetiapine, sertraline for her GAD, MDD. And in the hospital, so I think mostly she's resumed on her home medication. After confirmation of her methadone dosage, she was resuming 90 milligram methadone. And on top of that, and she's getting IV antibiotics, and additionally, she's getting PRN pain medication, including oral hydrocodone 5 Q8 and the hydromorphone 0.2 Q3 hours as needed. And we delved into a little bit of social history. Just she had a trauma history. She's been disabled for quite some time. And she, like I mentioned, she had a below the knee amputation on the other limb. She's wheelchair bound for most part. She's married, had dropped off of high school at 12th grade, living with husband with supportive family members. Depression, anxiety was noted previously, also had prior suicide attempt ×1 by overdose. These are all upon chart review. We didn't get too much of a prior social history as much. So briefly, hospital course, because of her foot infection, she underwent left foot amputation and also had a skin graft applied with subsequent wound vac application, treated with IV antibiotics, culture found to be multimicrobial, and she was discharged on PO antibiotics, follow up with infectious disease outpatient. At the point of discharge, I'm already off service. I'm directly involved with the care. I went back and did a chart review. Now she was not discharged with additional pain medication other than her home gabapentin and methadone. So just to fill in what had happened while she was in the hospital, I was taking care of her at the time. She had post-op pain. I had talked to her and offered to split her methadone to TID dosing and letting her know that this is just better for pain control. And I offered to communicate with her outpatient methadone clinic provider to let her know this is a temporary, it's not meant for be long-term. And with discussion, patient decided just to stick to her home dose, the 90 milligram at that time. So I think she did require a few days of escalated PRN, oral and IV opioid pain medication. And that was mostly what I had experienced. And like I mentioned, she had a history of heroin use, that therefore the methadone was used for treatment of opioid use disorder. I think what I found challenging is sometimes, although you explain what might be better for pain control, patient might also have their own way of, this is how I take it, this is the dose, this is the time of day. I don't want to mess up with my schedule. And also when she get discharged, what's going to happen at that point. So this is, I think, more than one patient have encountered similar situation. Thank you.
Thank you so much, Dr. Shi. And we will open up the floor for any questions or comments from our learning community here.
My main question was just, how was her pain in the like, did she do okay in the hospital with pain when she was there?
She acutely, for the post-op day 1 and 2, she did require frequent PRN medications. Subsequently, because I got rolled off the service, it's hard for me to say at that point if her pain is at without additional medication. So I would hope that was the case, but I just don't know at this point. I do wanted to share also, some of my colleagues are not as flexible or open-minded about treating patients with, you know, opioid disorder. They are a little bit not at a flexible, offering more, I guess, just more liberal pain medication prescription
Sure.
in that setting.
And, you know, I think that's where kind of advocacy and our like collegial interaction with everybody that we work with can sometimes help, and just sort of leading by showing like this can work, this could be okay. It sounds like we don't really know what happened, but maybe she did kind of okay. Looking at the case as far as like pain, like you did what it sounds like you did a really good job and totally talked to her and let her choose what she wanted to do. I'll say that the Oxy 5Q8, I mean, it's not very much opioid on top. So, you know, I want to make sure other people are jumping in, but does anybody have questions? I have a few things that, one that's like not even like your question related, but just a big alarm that goes off for me as a psychiatrist and consultation liaison. We talked about drug interactions. Does anybody know about linezolid?
Oh, the serotonin.
Yeah,
Right.
so it's an MAOI in effect.
Yeah.
Antipsychotic,
I don't know if they caught it.
Yeah,
ID.
not everybody has problems, but being on
Right.
sertraline and methadone, that's a high dose, and linezolid would make me go, eek, and what can we get off while she's on the linezolid? And sertraline would be like the indication, obviously, just something to kind of bear in mind that's separate. Does anybody have any other thoughts about, say, we heard that she was really struggling with pain with that regimen? Like, does anybody have any ideas about what you might be able to do with the regimen that was there, or changes that you might make, especially in the context of like hearing the lecture a bit ago? Like, any thoughts?
Split the methadone dosing.
Yeah. And it sounds like Dr. Shi had sort of offered that. The patient really didn't want to do that. I will say that it doesn't have to be TID. Like, again, you sort of say, well, what if we give you most of your dose in the morning, but just give you like a little bit for the breakthrough that you're having in the evenings? Like, here's 80 and let's give you 10. And then they get used to it and they see how it goes. You know, I also would say, I didn't talk about it, but if someone's been in a methadone clinic for a long time and they're on takeaways anyway, where takeaway meaning like they don't have to come in every day and they take like a week's supply at home, it's their supply to use appropriately. And so then the split dosing gets to be a little bit more, it's like they potentially could do that. I'm always liaising with the providers in the community. You can also think about increasing the dose of the methadone. If they don't want to split it, the increasing may or may not make a difference, but you could say, okay, take your morning dose, but let us give you a little extra at night, like a 10 at night that's extra on top, and see how you do, plus the breakthrough kind of, immediate acting pain control. And sometimes it does help. Anybody have any other thoughts of like the regimen that you saw? if her kidneys were functioning okay, the gabapentin dosing looks like it had room to, that it could have gone up if she was really struggling. And it can also help with anxiety if somebody's having a lot of anxiety about having their poor leg amputated.
Yeah.
In addition to just neuropathic pain, kind of the obvious indications.
Yeah, Kristen Jansen. I'm a pharmacist. I think one thing that comes up a lot when we have these situations, especially with severe acute post-op pain for patients who are in this kind of setting, 90 milligrams of methadone is probably somewhere on the order of 1,000 morphine milligram equivalents. And when you think about opioid potency, and so I think for these patients, we oftentimes very much underdose their PRN therapies. And if she's doing well, that's completely fine. And I think it's a conversation about a lot of them want to avoid more opioids. Some of them might, some of them not. But I've seen patients screaming in pain in their room because they're being given standard opioid doses when they are very opioid tolerant. So in patients who are not well controlled, oftentimes I recommend using like short-term PCAs, and there oftentimes needs to be some parameters and discussions about that, whether it's something that they're willing to do, interested in doing, and kind of having a plan for how we're going to come off of it. But I feel like what I see in practice most often is these doses that we use for standard patients are just not going to touch pain when you're already on that much opioids. And things like PCAs, while people I think sometimes get scared at high doses, are actually pretty safe, because if you are altered, you can't push the button. We can monitor their oxygen saturation and see how the patient's doing and make a plan for tapering from there, especially when they're in extreme pain, which I've seen some of these patients just be in incredible amounts of pain because they may also not have gotten optimal pain control in the OR or in PACU, in which they probably have a standard order set that's going to have somewhat lower doses of opioids than what this patient is going to need to get a response.
Thank you, Kristen. That's right on.
I have a quick question, kind of follow up. If this patient were to have uncontrolled pain, if she had required more pain medication on top of the 90 milligrams she was taking, what would be the best approach at discharge? Ideally, I have built this relationship with this outpatient opioid pain clinic provider. Will let him or her know what's going on at the hospital setting. And would they be the providers manage this post-op pain with increased opioid use, whether it's increased methadone split dosing or a short course of other opioid pain medication on top of her regular dose of methadone? Or it be a multi-team approach? Would there be a controlled substance agreement, conflict, things like that? What would be your recommendation?
Well, again, I think there's no right answer. The methadone clinics are not going to be willing to manage pain. The methadone clinic doctor is not going to be the one. And really, in my mind, where's the pain coming from? If it's coming from a cellulitis,
right?
Okay. If it's coming from an amputation, at least in our hospital system, the surgeons are the ones who are going to be following up in a week or two for post-op checks and things like that. And we encourage them to prescribe the appropriate pain management regimen for, they can max give a week at a time. And then, there needs to, I think the ideal is like a treatment team approach with everyone kind of talking with each other, but I don't think that really happens very often. I think also the idea of having like a pain management doc is hard to find, hard to get for most patients if you didn't already have one. If you have the luxury of already has it, great. Like call them, they're in charge, let them take the lead. They'll tell you what to prescribe. They can take it up if the patient needs it later. And if you have, it's sort of depending, I think, on the culture in your community, what your relationship is like with, for instance, like a buprenorphine clinic and the clinic docs there. And so it really depends on how narrow they look at their scope. more wide. They might also be, for instance, the patient's primary care doctor, like in addition to their buprenorphine doctor. So I think it sort of depends on that. I don't know what other people's thoughts are. I think there's not a right answer. But I think appropriate pain control is the most important thing. And if we would send anyone else home with an amputation with a weak supply of an opioid, you have discussions with your patient. You mentioned opioid contracts, like, substance use contract. Does anyone have any thoughts about those in general? Any experience?
Lindsay?
Yeah, so my experience is like suicide contracts, they don't work, right? I've used, I've had people who came in to, I'm a peer first of all, I'm a peer specialist. So I work with people on a little bit different level, but yeah, I have not found them to be effective for substance use or suicide. And a lot of it's just because it's not like they don't mean to, right? So when you sign something, you're like, yeah, that's fine. That's definitely going to happen. But then things happen and life happens, and so it's kind of hard to stick to. I think part of it, is if you do want to have a contract, there has to be some type of like check-in or accountability. Like how if you just have somebody sign something and leave, there's not any way to make to follow up with them and to keep them encouraged is more what it's about, right? So it's about like accountability, more about encouragement, because that's what it is. If you get that one split second where somebody's like, oh, I can't do this. Well, if they have somebody like a peer that they can call and say, this is where I'm at, we can talk to them and work with them, as opposed to just leaving them alone, which usually doesn't end well.
Thank you. That's really helpful. And I think for providers in the hospital system, I mean, behavior contracts, suicide contracts, not breaking a substance use contract, they don't protect your liability, I think is the most important takeaway. It's really, I agree with Lindsay, it's really just about having a good informed discussion with your patient and weighing the risks and benefits and coming up with a plan that you both feel like is reasonable, and then documenting well. And I think it's the best you can do. I do always try to talk about harm reduction with my patients as they're leaving the hospital or in anticipation of when they're leaving. And I think you have to decide it's okay if a patient's doing fine. She sounds like she was doing fine on what she was on. I don't know that she needs to leave on 5 milligram oxys 3 times a day. If she really felt like she needed some, I don't think it would be inappropriate, but maybe she was doing okay without it. I think everybody's different. I think there's always going to be a natural tension of, oh my gosh, I'm sending someone home with some short-acting opioids who has a history of this. But I think not to forget that they're on treatment. If you're sending them out on buprenorphine and they're getting a very short supply of opioid on top of it, like it's not like they couldn't access that in the community if they wanted to. If anything, you're protecting them from seeking pain control that's appropriate from a dealer instead of the weak supply of appropriate taper that you're helping guide them do. So, I think there's always going to be this do I, don't I? And I think in general, when we talk about sort of liability, it's sort of letting what's clinically reasonable, what the best, way to meet that patient's needs that you think is reasonable is usually going to be the most reasonable thing. And needless inflexibility, as long as you're not doing anything that's actually illegal, which obviously we're not talking about, needless inflexibility usually isn't going to serve you or your patient, and just makes things harder and sort of puts them through a little bit of torture when it's not necessary. It doesn't have to be so hard. But I think not to underscore, there's a lot of angst and there's a lot of misinformation and stigma around this area.
Thank you.
Can I also say that I do think, however, that this is that's a great time if you're going to send somebody home with pain medication, that maybe bring up something like pulling in a peer support specialist who they can talk to and work with, or even if they're even if you're not seeing them home medication, just somebody that they can really talk to about it and kind of have as a backboard if they are feeling like they're needing something, talking to somebody about it is helpful. And sometimes it's easier to talk to somebody who's been there.
That's awesome. I totally agree. Sort of, you know, it's sort of a part of the discussion of how can we help support you, because you are going home with something, especially if they've had like a history of misusing that particular, like pain medications, pain pills in particular have been a risk. You know, they also have street value. And you know, I think looping in more support, whether it's a recovery specialist or just their family, their spouse, their, you know, adult child, whatever it is that they have, if they have someone to kind of help them start thinking about, you know, helping support them through that. And discussions with your colleagues, if you're not the one who's going to be prescribing it, of what to watch out for, and that, you know, it's okay to say, hard stop, this is all I'm comfortable with, this is all I feel comfortable giving you. Let's look at other agents that aren't opioids and, you know, bolster those, because after the next follow-up, I'm not going to feel comfortable, you know, refilling it. And that's okay too. But I like that. Thank you, Lindsay. To make sure you're sort of coping ahead. I use that in psychiatry, but having that discussion with your patient and how we're going to help support you through this acute pain episode as you're going home and trying to stabilize again. And encouraging, for instance, say they don't go as often to their methadone clinic or their buprenorphine clinic. Maybe it's a time, kind of like when someone's in more of like an acute mental health crisis, to see their provider more frequently and quicker. How we see OB patients that have been struggling after labor, like to come in faster than they normally would, to think about getting them in front of their support system in the clinics quicker and more often, in just like the acute post-op period or post-hospitalization period, so to speak.
Thank you so much. This has been a great discussion. And I think, Dr. Walker, you kind of summarized it, but if you could maybe give a quick summary of the recommendations for today's case.
Sure. So for this case, I guess the main things that we kind of ran through were the idea of splitting methadone, being generous with opioids, keeping an eye on drug interactions as an aside, and then adding in just the psychosocial support piece and having sort of a plan for the patient both during the hospitalization but also afterwards. Dr. Shi, were there any other questions that you felt like you needed to get answered before we wrap up?
No, I think you answered most of this case really well. I think it's just a cultural shift and multi-team approach. And I think those are really helpful tips and involve peer support. Thank you.
It was a great case. Thank you so much for bringing it to this venue.
Thank you.
And I'll say the culture is shifting everywhere. And you know, we work in a hospital where we've been around doing this for a long time, and it's still a struggle all the time here too. So it's gonna take a long time to kind of move the culture. All we can do is keep on trying.
Thank you.
On that note, thank you all for joining today's ECHO session. As a reminder, to earn C credits, please text the activity code 100-929-06 to 844-502-1338 by midnight today. We also request you to complete the post-session survey using the link in the chat. The survey will be open for 1 week. If you would like to present a case, please email bwelltx@utisca.edu. We'd look forward to seeing you at our next session, which will be on Thursday, June 15th. Thank you and have a wonderful rest of your day. Bye-bye.